Hi, class. Welcome back. It's Dr. Lindner. We're still on neurology, but now we're going to be looking at some spinal reflexes, which is an interesting topic. So, when we talk about reflexes, they're automatic responses to changes in the environment. And the integration center for spinal reflexes is the gray matter of the spinal cord, right? So remember, if let me get if we have the cross section here. Oh, let me just, sorry about that. Let me clear that up. If we create a cross section here of the spinal cord and we do the butterfly here in the middle, right? Remember this butterfly, everything in here, this is gray matter, and everything around it is white matter. So the integration takes place here in the gray matter. So what are some classical examples of some reflexes? So we have somatic reflexes, which result in skeletal muscle contraction. A classical one that we can all relate to is your hand touches a hot stove, reflexively you withdraw quickly. If you didn't have this reflex and your hand remained on the stove, you'd be smelling your flesh burning, right? So quickly it withdraws. There are also some autonomic reflexes or visceral reflexes that involve smooth muscle, cardiac muscle, and glands, like heart rate, right? When you hear a loud noise or a bang, your heart rate goes up and your respiration increases, or all of a sudden you go, I got to run to the bathroom, urination, right? These are autonomic reflexes. And we also have, when we cover cranial nerves, we'll go over some cranial nerve reflexes that are kind of neat. Shining a light in the eye and watching what happens to the pupil. Um, Putting a tongue depressor and hitting the back of the throat for the gag reflex, cranial nerve 9 and 10. When I say two cranial nerves like 9 and 10, the first one's always sensory and the second one is always motor. So when we do pupillary reflex, it's 2 and 3. 2 or optic is sensory, oculomotor, 3 is motor. It's always sensory then motor. Carotid sinus reflex, touching the carotid region can decrease your heart rate. Again, cranial nerve 9 and 10. Pressing on your eyeball gently is the oculocardiac reflex, 5 and 10. All right, so there are some really neat cranial reflexes as well. Let's talk about the reflex arc. There are 5 components of the reflex arc: 1, 2, 3, 4, and 5, and you should know them in order. I numbered them on the left, and you can also see them on the right-hand side. So let's just talk it through so we could see what's happening. Also, pay attention to the cross section of the spinal cord. Everything back here is posterior and everything up here in the front is anterior. If we draw a line right through here, we know that because right there, that's the dorsal root ganglia. So everything back here is dorsal and everything back in front here is ventral or anterior. So we have, number one, a sensory receptor, right? So we have these receptors in the skin. We see that there's a thumbtack or a pin or a needle that hit the skin, and you could feel that and go ouch, right? But how do we feel that and go ouch? Because the skin is not doing any feeling, okay? So this information hits a receptor. So number one is receptor. That information is moving up this neuron. What type of neuron is this? It's a sensory neuron. It's picking up sensory information. So it's going through this sensory neuron, through the dorsal root ganglia, all the way here where it's going to synapse in that dorsal horn, right? This is the dorsal horn. Here is the ventral horn, okay, or anterior horn. So this is a sensory neuron. The red is a motor neuron. The sensory information has to be relayed to the motor neuron. Where is the relay? it's number 3, which is called the association neuron or the integrating center. Okay. Association neuron is probably the better term. That's what most of your lab instructors will probably call it. But understand, because it exists in the gray matter, that's where the integration is actually taking place. So the association neuron, aka interneuron. All right, they're both, it's either interneuron or association neuron. That's the relay. Then it sends it to the motor neuron, which will send it to the actual effector. In this case, it's the muscle that withdraws. All right, so you should know the 5 components of a reflex are receptor, sensory neuron, association neuron, aka interneuron, motor neuron, and effector. We'll talk about these 4 important somatic spinal reflexes. We'll talk about the stretch reflex, the Golgi tendon organ reflex. Number 3, we'll talk about the flexor reflex. We'll talk about the crossed extensor reflex. Well, let me make sure my pen is on here. Okay. So let's take a look at the stretch reflex first. So the stretch reflex, this is like when you hit the reflex hammer over your biceps tendon or over the patella tendon. Okay, this is the stretch reflex, known as the patella reflex or bicep reflex. But its design is also, besides that, is to prevent injury from overstretching. So whenever a tendon or a muscle is overstretched, it will contract to prevent overstretching and tearing of it. Okay, the muscle spindle is the actual receptor that's detecting the amount of stretch that's in that muscle or tendon. Okay, so let's take a look. In this particular example, we have a reflex hammer that is hitting the patellar tendon of the quadriceps. So when the reflex hammer hits it, right, understand that it's going to stretch that tendon, right? Because when you hit it, it's going to deform it. So it puts a stretch in, and what's picking up the stretch is the stretch receptor, which is the muscle spindle. So there's a stretch, and that information from the muscle spindle is going to move up, number 2, that sensory neuron. The sensory neuron comes in through the dorsal root ganglia into the dorsal horn. And here's where the integration takes place. And it's going to relay that information to the agonist and the antagonist. You can see that there's a solid red line going to the quads, and then there's a dotted red line going to the hamstrings. Now, we know what happens when you hit that patellar tendon, the leg extends, right? You see the arrow over here, and the arrow is going to lift or extend the leg up. Now, the only way that can happen is if there's excitation to the quads, because the quads are responsible for extending the leg, but there has to be inhibition to shut down the hamstrings. If both the quadriceps and the hamstrings were stimulated at the exact same time, you wouldn't get any movement. So the solid line, you see the plus right here, the plus, so that's excitation, and the minus is like inhibition. So the quads are stimulated, the hamstrings or the antagonist are shut down, and when this is activated, you get pure extension. Okay, so that's the stretch reflex. Now, this can also happen think of what happens if you're standing and you bend down to touch your toes. You start to feel a stretch in your hamstrings. And if you try and touch your toes a little bit more, what happens to the hamstrings? Because it's being stretched to prevent that from tearing, the knee bends. And when the knee bends or buckles, it gives a little slack to the hamstrings to prevent it from over tearing. Let's look at the GTO, the Golgi tendon organ reflex. Now, this is going to be, when I think of the GTO, I think of an arm wrestle, right? If you're having an arm wrestle with someone, if I'm arm wrestling someone and I say go, like let's say I'm arm wrestling my youngest son, and he's really giving it all he has, and I'm arm wrestling him, and he has no chance of winning, right? If he's continually applying such tension to his arm muscles, and I'm stronger than him, what will happen to his muscle or his bone? It could break. So what happens is when there's so much tension that's being generated onto that, the muscle just gives and it blows out. Okay. So here in this particular example, let's pretend that now the quadriceps, the person is doing leg extension. So there's weights and resistance over here, like they're doing leg extensions at the gym and they're lifting their leg and extending it. Now the quadriceps are picking up a lot of tension because there's a lot of weight that we're trying to extend. So we're extending the leg up. Here we have the Golgi tendon, the GTO, the Golgi tendon organ, which we see right here, that is picking up the amount of tension. That sensory information goes up the sensory neuron. It relays it, again, the interneuron or association neuron. And once again, we're going to see output or motor output going to front muscles and back muscles. Okay. Now, in this case, look where the negative is. You see the dotted line is going to the quadriceps because there's so much weight, there's so much tension, I can't handle it anymore. So it shuts down the quads and activates the hamstrings, and boom, we're able to flex the leg. This relationship between agonist and antagonist, the way it works together, it's called Sherrington's law, or law of reciprocal inhibition or reciprocal innervation. Okay, it works. It's that functional relationship together. Now let's look at the withdrawal reflex. This is what happens if, let's say, you touch something hot or you step on something sharp or hot and your leg pulls away. So right here at number 1, we see that there are pain-sensitive receptors here that pick up the painful stimulus. It's going through a sensory neuron. And again, let's just focus on the middle for a second. The sensory information goes in the dorsal root. It synapses at the dorsal horn. We have the interneuron, aka association neuron. It relays it right here to the anterior horn, where we have the motor neuron that goes right to the hamstring. When it activates the hamstring, what happens? The leg flexes, right? Super quick. That's the withdrawal reflex or the flexor reflex. Pretty cool, right? We have no time to send information to the front muscles. Hey, we just want to withdraw from the painful stimulus. That's pretty cool. Now, what happens in the same situation, if we focus here on the left-hand side, the left-hand side is the flexor reflex, same exact situation. You stepped on a tack, painful information goes up the sensory neuron. It synapses right here to the association neuron. The motor information goes to the hamstrings and you withdraw from the painful stimulus. But at the same point in time, we have information crossing over to the other limb, right? So this is the right leg. If you withdraw from the right, what has to happen to the left? The left one has to extend. So we have activation and excitation going to the hamstrings of the painful stimulus side, but we also have an active contraction on the opposite limb going to the quads to make sure that the leg extends. And that's why we call it the crossed extensor reflex, because the information crosses over to the extensors on the opposite side. Okay, now this only happens of the lower extremity. because you're not going to touch something hot with your right hand, withdraw, and then have your left hand extend to the painful hot burning stove, right? So you understand that the crossed extensor reflex only applies to the lower extremity. It doesn't apply to the upper extremity. Clinical considerations. Okay, here's something that's kind of important. Checking the patient's reflexes can help to detect certain disorders. So we will go through reflexes at every level of the neck and the lower back, like checking a biceps reflex, a triceps reflex, the patella reflex. So we will go over that in another video. But here, I just want to talk about the clinical consideration of what's called Babinski's reflex. So here, what we want to do is take the reflex hammer. Let's see if we can find that. And you want to take the reflex hammer, but take the blunt side, and we want to stroke it underneath the surface of the foot, okay? And what we want to see is this plantar reflex. This would be normal in an adult. If we see this happen in an adult, it's called Babinski's sign. It's abnormal. If we see the great toe extend and these toes curl down, that's abnormal in an adult. It typically means there's some sort of upper motor neuron lesion, some sort of damage going on in the brain. Okay, we'll see it with maybe a person has a stroke or maybe MS, some sort of lesion that's happening in the brain. The only time this is normal is in a baby. The only time you want to see this happen is in a baby, not in an adult. Okay. Let me go back here for a second. So the Babinski response is normal in infants, but it can indicate damage in the brain, in the CNS, but especially in the brain.